Has the U.S. done enough to manage the COVID-19 pandemic? Today on Medical Economics Pulse.
So we're starting to see some creative ways to get those tests in the right place. Here's the challenge that I see. It's sporadic, it's not consistent because the FDA lowered their kind of what you have to do to, kind of the barriers to entry. As we saw all in the lay press over the last week, they're inconsistently good or not. But more importantly, we still haven't made good public health decisions.
Defeating the COVID-19 pandemic will require robust testing and tracking, and that means physicians will have a key role in flattening the curve. So, how are we doing so far? And what will physicians need to do in the future to aid these public health efforts? Today, we are joined by Dr. Halee Fischer-Wright, President and CEO of the Medical Group Management Association, to discuss the state of the country's COVID-19 response and the role for physicians moving forward. Dr. Halee Fischer-Wright, thank you very much for joining us today.
Thank you, Chris. I appreciate the invitation.
Thank you. So to start off, let's talk a little bit about sort of assessing how this pandemic has gone so far. Obviously, it's an unprecedented situation. It's something the nation hasn't seen for decades, a century.
Yeah.
How do you think it's gone? What could we have done better? What do we need to do going forward to really get a handle on this?
Well, so I think this, how I approach things is what's working, what's not working. Really simple platform. So if you look back and you say what wasn't working, what didn't work is not having appropriate testing. We can get into a big political discussion. It's not really the goal. From a public health standpoint, let's talk about what hasn't worked is the testing. What is working and what I have amazing, I'm so impressed, and honestly I feel, for lack of a better word, patriotic, is how some of the communities have really lived into shelter in place to protect their own communities. So in regards to testing, what hasn't worked is not testing. What hasn't worked is having timely, reliable testing. And we see that playing out now, even though it was pretty clear the last week of February things were going, we are now going into the first week of May, that's still a problem. Why is that a problem? I think people really don't understand why that's a problem. On one hand, they say, well, I've heard this, I think I've heard this 3 times this morning. I hear this every single day. I think I was sick at the beginning of the year, I must have had COVID. What we need to recognize is we don't have a good assessment of how much COVID is present just today in our communities. So there was basically a study out of Stanford that was released on Monday that showed that in I can't even remember, near the Stanford facility, that just doing antibody testing, 4% of the population had COVID that didn't even know they had COVID. So if you assume that endemic already is 4% in the community, we would approach the public health very differently than assuming that no one has it. The other thing is, if we assume that the community has 4%, just wild, didn't know about it, that changes our death rates tremendously, because then it becomes the death rate is similar to influenza. I want to be really clear. I'm not saying that the disease is just like influenza at all. What I'm saying is, if you just assume that there's a 3 to 4%, everybody has had COVID-19, that means the fatality case rate is 0.01%. Now, where that number gets real scary is if there's 350 million people in the United States, we're still looking at death rates that are very high just with that. And so, but that helps us to really strategize how we treat people in the United States. And very much you hear this mixed message of it's going to go away, it'll be fine, versus we're going to have this for 2 years. And, I can say is, my husband's mother, who's in her 80s, has been locked down for 8 weeks. And the conversation that we've had with her and with my father, who's on oxygen, who has lung disease, is you guys aren't leaving your house for 18 months. So, just re-up on Hulu, re-up on Netflix, This is what your life is going to be, which is different than my state is loosening on the office with high rules. We're looking at a rolling introduction of our healthy employees back in the next 3 to 4 weeks, 20% of the time. And so you're navigating multiple different models, trying to figure out what works. And I think the big thing to notice, to take away from this conversation, is plans will change. To your point, Chris, we haven't done this. I mean, even 100 years ago, we didn't do it that well. And apparently we didn't learn what we should have 100 years ago in preparation for this. So I think it's like the one constancy is change. The one constancy I think we can take away from this is plans will change, and that we do have to learn a certain amount of flexibility as we learn more information. I reflect back on the last 6 weeks where I hosted a large conference in Nashville, which is probably where I got my COVID when I had it the first week of March, is in traveling, to where we are today, 6 weeks later. And just the wealth of information, how we're approaching things has just dramatically changed in 42 days. I'd like to think 42 days from now we'll be that much smarter.
So in terms of testing, I'm just kind of curious what you are hearing from your members.
Yeah.
Do they have tests available for their patients? See, that's what I thought you were going to say.
Nope.
It seems to
No.
me that testing is available. Like if you get hospitalized, then you probably have a test available to a certain extent, but otherwise there doesn't seem to be testing. So you kind of talk a little bit about what you're hearing from your members.
Yeah. So Abbott released their antibody test last week. That was given in large part to first responders in hotspot areas. A lot of people now have that Abbott box, if you will. They don't have the reagents to run the test. So those boxes were distributed throughout the United States. And it's actually a very good test, a reliable test. But no one has the reagents to run it, which is the problem. And that's where a lot of the politics comes in, because those reagents, by and large, come in from China. That being said, I saw this morning that other large pharmaceutical companies out of Switzerland are going to be releasing their tests. This morning, LabCorp announced that they were going to do direct-to-patient testing, that you could get a note from your doctor's office, they would FedEx you, you swab yourself, and then you could send it back to them and they'd run it. So we're starting to see some creative ways to get those tests in the right place. Here's the challenge that I see. It's sporadic, it's not consistent, because the FDA lowered their kind of what you have to do to, kind of the barriers to entry. As we saw all in the lay press over the last week, they're inconsistently good or not. But more importantly, we still haven't made good public health decisions. So to succinctly answer your question, I do know practices that have some testing. They have 25 tests. Okay, I don't really know, and there's just a few of them. I know some states who don't have enough testing, Colorado being one of them. We're still not doing enough tests. California has good testing. New York doesn't have enough tests. North Carolina is in between. We do see states who really aren't doing testing unless their people are being admitted to the ICU. So it's a real hodgepodge across the country.
Okay, what are you hearing about PPE? Obviously, there's been a ton in the lay press about healthcare providers not having enough protective equipment. What are you hearing about that?
So PPE, so the first thing we heard was we don't have PPE to see patients from practices. And then about 3 days later was we don't have cash to run the practice. So even if we could find PPE, we couldn't buy the PPE. That's kind of that was the first and second wave. Now that we're several weeks in, what we're finding out is practices have become amazingly resilient at finding PPE. So let me give you some examples. People have figured out how to reuse N95 masks. When this all started, I visited one of the intensive care units here in Colorado, and basically as you went by the front door or the door to get into the ICU, there were bags, like old-fashioned grocery bags that had people's PPE, their N95 masks in it, and they just kept them in these brown bags. And by the way, they weren't labeled, so you didn't know whose mask was what. That was wave one. Now we're seeing hospitals figure out that they can use ultraviolet light, certain kinds of gases to clean those. And so now we see that going much better. We see distribution through federal supply chains, those kind of things. And medical practices, a lot of medical practices have actually taken to going to Home Depot. Home Depot seems to be the place of choice. And for some reason, Home Depot, in a lot of ways, had better supply chain for providing N95s, face shields, et cetera, goggles, than a lot of our medical suppliers who just didn't have the supply chain set up on a national level like we've needed. So do I still think there's shortages of PPE? Yes, but certainly not at the catastrophic levels that there were 6 weeks ago.
What, in terms of sort of the PPE issues,
Yeah.
and the sort of, obviously that example of Home Depot is extremely interesting, and it makes
Yeah.
you wonder how we got there. And so I'm kind of wondering what you think needs to be done to sort of help to alleviate for future pandemics, because
Yeah.
there's always going to be another pandemic at some point. And what do we need to do to make sure that these basic equipment that medical providers need, that we don't have a shortage like we do now?
I think that's a really interesting question, because I think your first point is we should stockpile tons of this. But the truth is, would we have stockpiled stuff for 100 years before we needed it in this way? That doesn't make a lot of sense. What I think there's a kind of a misconception. People assume that healthcare is a system nationally, right? And the truth is, we're not a system, we're an industry. Multiple players, multiple agendas, multiple different values, multiple different goals. So I think what needs to be developed is actually the supply chain plan to implement, where the federal government or FEMA leads it, oversees it, but that they're regional arms, so that we can, it's not a let's stockpile so much, but it's more, how do we get this up and going within 2 weeks? Because there's always a time lag between you're first aware of something and it hits. In the United States case, it was anywhere from, depending on what your philosophy was, did the virus hit us at end of December, January, February, or March, right? So, but there was time there to activate supply chains and to ramp up on development of provisions and things like that. I think that's where the federal government can take the lead, is just owning the plan and making sure that there's clear accountability. And that's actually where I see the flaw right now, is that we have 50 governors acting on their own agent, competing against our federal government to try to get the same resources without a clear delineation of who does what, where, when, and when those resources are going to arrive.
Okay. Let's talk about burnout and stress, because obviously right now physicians are, and other healthcare providers are going through an incredible amount of stress. I mean, we all hear about, there's a lot of that they're talking, that they're acting the most heroic people right now in our society. They're really putting their lives on the line. And I'm just wondering, what do we need to do, both as a healthcare industry, as a society, to support healthcare providers and physicians who are really going above and beyond right now to help deal with this pandemic?
Yeah, I think the first thing to focus on is safety. I think one of the biggest contributors to burnout in providers during the COVID situation has been the fact that they couldn't really protect themselves because they didn't have appropriate PPE, and they couldn't protect their families. They were putting their own families at risk. And that is a tremendous soul burden, emotional burden. I know of physicians who have partners who have moved out because they didn't, they worked in, for example, an emergency room or ICU, and didn't want their kids or family members to be exposed. So they're separated right now. So I think there's an acknowledgement that while healthcare providers, first-time frontline responders are heroes, there's a certain amount of risk that they're taking that is exceptional, that was unanticipated, of fighting a foe that we have no idea what it is, how it's going to affect anyone. And so I think acknowledging that, and as a society, we need to do what we need to do to make sure that our healthcare providers are safe. I think certain areas have done that better than others. I also think we need to make sure what we're asking our frontline providers is reasonable. So let's take New York out of the example, because that was so extreme. But even if you go to any metro city that isn't a hot spot, what we're asking providers, the shifts we're asking them to do, we're not giving them a conscious choice, if you will, of are you aligned with this? And I think providing safety, providing security, having those conversations, and then not asking them to do things above and beyond their tolerance of risk, I think is an important part of the conversation. I think it's a much more, at first it's a crisis, let's go. But now there's an intentionality because this is not going to go away for the next 2 years. And so I do think we have to realign our expectations for our providers to create sustainability so we don't burn out everybody.
And sort of a kind of a related question is, what do you
Yeah.
feel like physicians need to do to help each other? Obviously, the only ones who truly understand what physicians are going through are other physicians. And I'm just wondering about like, what's your advice in terms of peer support and sort of colleagues reaching out to colleagues?
Yeah, I think the interesting thing about this crisis is it's forced us to slow down, society-wise. The other thing is it's either isolated you in an extraordinary way or it's connected you in a way that you didn't expect. So we just talk about social distancing, not emotional distancing. Physicians, speaking as a physician, have been trained to really compartmentalize our emotions, to not discuss what we're feeling, that there's expectations, internal expectations, external expectations for delivery of care. This is where I would poke on my colleagues to say, we need to talk about it. We need to talk about it in safe spaces with our colleagues. To your point, Chris, the only people that know what we're going through are other physicians, but we do need to really spend and invest in creating those connections, maintaining those connections, building those connections during this time period, because that's what's going to sustain us. It's being in a meaningful relationship and being close in that relationship that's really going to allow us to move past this in 2 years.
Yeah, sort of my final question was going to be about the time frame. Obviously, there's been a lot of talk in the news this week about this fear of, I think the CDC director was reported of saying that there's this fear that there's going to be a surge in the fall, and that's going to correspond with the beginning of flu season. And I'm just wondering, like, so what in your sort of like the best information you have right now on the ground, what should physicians and other healthcare providers sort of expect over the next year? Obviously things are always changing, but what expectations do you have for what things are going to be like going forward?
I think if you take a look at if you compare, you opened this interview about comparing it with the 1918 influenza epidemic. And what we saw in that pandemic was there was a first initial wave, and there were actually 3 waves, then another wave, and then later another wave. I think it's reasonable to assume we're going to see the first wave, which we're in right now, but then we're going to see a second wave. I do expect it to hit in the fall. The CDC director's warning is it's going to be worse. No, it's not going to be worse than it is today. What it is the aggregate effect of having sick people with influenza and sick people with COVID, which kind of creates a synergistic spike in utilization of healthcare resources. It's not that COVID's worse. And I think people get that message confused. And I do think we're going to, depending on the timing of when we receive a vaccine, I think we could see another spike late in the spring, just like this. So what we know about this disease is it's not seasonal like influenza. And so I think people are thinking, oh, well, when it gets hot, it'll go away. Well, it's in Singapore, it's in Hong Kong, it's in Australia, it's in Brazil. It's hot, it's not going away. So I think what we're going to see is it's going to be around all year long. And we're going to see ebbs and spikes depending on what population it's affecting. And I think the other thing to take into consideration that didn't happen in 1918 is there is so much travel, at least there was till about 8 weeks ago, that spreads disease around in a way that you can't contain it. So I'm thinking there'll be at least 2 peaks. There'll be the one we're in now that's going to lighten up as we go into July, August. Then I expect to see another peak, not as high for COVID, but another peak probably, starting September, October, November, go into January. And then depending on the timing of the vaccine and how it's distributed, I think we're going to see another peak at the same time. Each one will be lesser and consume less of resources. Every time it happens, you're going to know exponentially more about the virus. But that's what I think we can reasonably predict. And that's what I'm actually asking our businesses to prepare for.
Great. Thank you very much. Dr. Halee Fischer-Wright, thank you very much for joining us today.
Thank you, Chris.